Hey guys, so I want to get this lecture recorded and I've tried a million times, but I'm actually going to sit down and do it, and in its entirety right now. So anyways, I wanted to start out just kind of going back through some A&P stuff. So when we think about the heart, it's a lot easier if we know the blood pathway, and then we can it helps us with the electrical pathway. So when our heart beats, the blood comes in from the inferior vena cava here, and the superior vena cava, where's my mouse? Right here, into the right atrium. That's when, and I don't have the SA nodes and the AV nodes in here. This could be a lot more detailed, but I just kind of wanted to show it to you. But the SA node is right about here. So when that blood comes in here and fills the right atrium, the SA node sends off a signal that says, hey, we need to contract. So then the blood flows down to the right ventricle down here, into the pulmonary artery right here, and goes out to the lungs. From the lungs, it comes back in through the pulmonary veins on both sides. You can see they're on both sides, into the left atrium, down into the left ventricle, and then up through the aorta here, and then out to the body. So we have an SA node here, and we have the AV node here, and so our atria contract at the same time, and our ventricles contract at the same time. So the right side of the heart is putting blood to the lungs, and the left part of the heart is putting blood out to the body. Hope that makes a little bit more sense. So then when we start talking about our rhythms, it's a lot easier to understand what the rhythm is just because we know how the rhythm works. So let's pull up this sheet. So I did post those 3 review sheets. So starting out, here is, in an EKG, obviously you guys have reviewed this over and over, and the one cardiac cycle is a P wave, a QRS complex, and a T wave. The P wave, technically it's the impulse or the electrical impulse for that atria to contract or depolarize. It's a lot easier if you consider it that it's the atria contracting. The QRS complex is also that electrical impulse, but it's the ventricles depolarizing or contracting. And then somewhere in that QRS complex is where the atria repolarize and recharge. So you'll never see an actual wave that says, hey, the atria are recharging, because it's hidden in that QRS. And then the T wave is after the QRS complex. That's the ventricles recharging or resting. So if we go to our heart strips, looking at these boxes, each tiny little box in this box right here, I'm really hoping you guys can see my mouse, is 0.04 seconds. So then each of these bigger boxes is 0.4 seconds, or 0.2 seconds, sorry. And that's how we measure how long our PR interval is, how long our QRS complex is, just by measuring it using these boxes and multiplying it. Let me go back up here. It's much easier when we're reading our EKGs to have a set steps that we go through. So you can do the heart rhythm or the heart rate, either one first. I kind of like to do the heart rate because that can tell me a little bit more quicker. The heart rate, when we're looking at heart rate, it's basically, overall, it's how many electrical impulses, the whole thing, the PQRST complexes that we see in 1 minute. If we want to count how many atrial beats there are, we count the P waves. If we want to count how many ventricular beats there are, we count the QRS complexes. If the rhythm is regular, we can just count R to R. So the 6-second method is probably the most, the easiest one. So I just got to find one with our marks here. So here's the beginning of the strip. Here's the 3-second mark. And then here's the 6-second mark. So this is a 6-second strip. We just count the beats, the R to R. 1, 2, 3, 4, 5. So if we're using this one and we're determining rate, this rate would be 50. I did put another way to determine, but I would much rather you guys use the 6-second method. You can look at this, but I'm not going to get too bent out of shape about it. Alright, so then we go to rhythm. It's either regular or irregular, but the irregular rhythm can be classified as regularly irregular or irregularly irregular. Just meaning that maybe every third beat is early would be a regularly irregular, or maybe like in a fib. There's no rhyme or reason. It's the beat just goes here and there, you know. There's no specific, it's not every third beat, it's, you know, wherever those ventricles decide to contract, wherever those atria contract. So the way to determine if it's regular, we are just going to look from the R wave to the R wave. We can do this by taking a piece of paper and marking the first 2 or 3 R waves, and then march it out and see if they match up. Then going on to our P wave. These P waves should be round and upright. It looks like a little hill. This is actually the SA node firing. And we want it to be regular. We want it to be before every QRS. We want them all look the same. So we kind of assess the P waves there. Some rhythms won't have a P wave. Kind of like a flutter does not have P waves. It actually has F waves, which are called flutter waves. So we always want to look at our P waves because that'll tell us what our atrias are doing. I gotta pause this to let the dog in. Hold on just a little. Alright, I'm back. So anyways, the PR interval, when we look at that, we're looking at how long it is. We want to make sure that it's in between the 0.12 and the 0.2 seconds, because when it starts to get longer than that, we're looking at a heart block. The PR interval actually, what's the word I want? Indicates how long that impulse is going from the SA node down the AV node down to the bundle pist, and then down through the bundle branches and then off to the Purkinje fibers. So it tells us about the type of block that we are looking at. QRS complex, remember that this is our ventricles contracting. So if there is an issue with our ventricles, this is where it's going to show up in the QRS. I'm going to find my mouse back. Alright. So, and we want them in between 0.06 and 0.12. So if you're trying to remember these numbers, they kind of go from one to the other. So our QRS, we want 0.06 to 0.12. And our PR interval, we want 0.12 to 0.2. So the PR interval takes right off the QRS if you're trying to remember where we want them. Alright, getting into some strips. So our first strip here is artifact. This might be that somebody's brushing their teeth, they might be shaving, maybe the electrodes are not attached to the skin very well. So all we do is we go in, we look at this strip, then we go look at our patient, because that's the number one thing. You can look at a strip, you can look at a machine, you can look at a monitor, whatever you might be looking at, but I always say treat the patient, not the machine. So anyways, go in, look and make sure that all the electrodes are connected correctly. Making sure that they have the whole thing is touching their skin. So, Sinus arrhythmia, I guess I just don't want to spend a whole lot of time on these normal ones. As you can see, the P wave is there, the QRS looks good, the rate is between 60 and 100, the rhythm is regular, both the atria and the ventricles. That PR interval is in between that 0.12 and the 0.2. QRS is right where we want it, so this is a normal sinus rhythm. Everything looks right where it's supposed to be. Down to a sinus bradycardia. This is just like a normal sinus rhythm, except for the beats are less than 60. So it's a slow heart rhythm. I do want to tell you that on this strip, the ST segment from the S wave to the T wave is elevated. So anytime you see that, you are thinking heart attack. So the first thing you want to do is contact your patient or your doctor. But yeah, so that right here, from here to here, is the ST segment, and it is elevated. Alright, back to where we're supposed to be. The bradycardia, everything's regular, everything's in between those time frames, except for this patient's heart is beating slow. They could be dizzy, could be having chest pain, shortness of breath. A lot of times, athletes will have a bradycardia. It's nothing because their heart is so toned that it can actually pump 40 beats a minute, and it is getting the blood to where it needs to be. So that's why I say always look at your patient. Tachycardia, same thing. It looks really good, except for it's fast. It's above that 100 beats. Sinus arrhythmia. This one is kind of difficult to see it, but it is right here. It's just a goofy beat. The rate is going to be within normal, the 60 to 100 generally. The rhythm, when you look at it, from here to here, it looks pretty regular. But then from here to here, this is shorter, so it makes it an irregular rhythm. There's a P wave that looks good before every QRS. The PR interval is within that time frame, so that looks good. QRSs all look the same. They're within their time frame. Except for this beat is early. And that's about what this is. Patient may be breathing because sometimes when they're sleeping or with inspiration and expiration, the beats will come a little early. So basically, if they're asymptomatic, we're not going to do anything. But if they do have any symptoms, we're going to treat the cause. Sinus arrest or pause, all that is a period of asystole. A flutter. The atria are beating rapidly, and it's still somewhat coordinated. So it's still where they're actually pumping some blood. They're not doing a great job, but they're still pumping some blood. The ventricles are going to be doing their own thing as well. They might be regular, they might be irregular. But what's important in atrial flutter is these F waves. Yeah, they kind of look like P waves, but between every QRS, there's going to be these like bigger P wave looking things. They're called flutter waves. And it kind of looks like a sawtooth. There is no way to measure a PR interval. All the QRSs look okay because it's atrial flutter and the ventricles are still doing their job, so they still are doing the correct thing, whereas the atria are not doing the right thing, so they're kind of beating effectively, just faster. I said kind of, not effectively. So, um, might be a mitral valve disorder, maybe the heart muscle might be thickening. For atrial flutter, we're going to look at cardioverting them, giving them an antiarrhythmic, and slowing that ventricular rate and the atrial rate. I think this is supposed to say atrial rate. I apologize. And trying to reduce their risk for having a blood clot, because when the atria are not pumping effectively, that blood's going to sit, and then it might start circulating. So we're going to make sure we're anticoagulating them. Alright, atrial fibrillation. This is kind of like atrial flutter, but the electrical signal is uncoordinated. So the atria are actually just quivering. They're fibrillating. They're not actually contracting, so they're jiggling like jello. The ventricles, however, are still beating at their own rhythm because that AV node gives them, tells them to contract, but the atria are just sitting there jiggling around. The rate, if you try and count the atrial rate, it'll be up to 400 beats a minute. Beats is not actually the word that I want to use, but if you, just to make life easier. And that ventricular rate's going to be variable. It can be fast, it can be slower. Because once it goes through the AV node and down, and the AV node is the one making the electrical impulses, it slows it way down. Anyways, there are no P waves. There's no way to measure a PR interval. All the QRSs are exactly the way we want them. They all look alike, and they're in between that 0.06 to 0.12, except for the fact that they are irregular. So, this is also another rhythm that we're going to want to give to be able to control the rate and get the calcium channel blockers, the beta blockers, the DIG going. We're going to make sure that they are anticoagulated, and then they may need cardioversion if they're not in a controlled rate. If it's above 100, it's considered uncontrolled. If it's below 100, it's considered controlled. So, SVT can also be paroxysmal SVT, just meaning that it comes and goes. The rate is 150 to 250. The rhythm is generally regular. The P wave, we don't really see the P wave in this rhythm because the beats are so fast and so close together that P wave is buried in the QRS. So you kind of have a QRS and a little P wave. No way to measure the PR interval. All the QRSs look good. They're in that 0.06 to 0.12. It just means that the SA node is firing a lot faster than we want it to. We're going to see this with stimulants like cocaine, stress, overexertion are the big ones. Treatment is going to be, like immediate treatment is going to be adenosine, which will actually, once you give it, it actually stops the heart. And these patients will have a period of asystole and then start beating in a normal rhythm again. It's a very scary situation, I guess. The first time you see it, the first time I saw it was on a friend of mine. So, and I was the nurse. So yeah, it was a little nerve-wracking. Plus, she was about 8 months pregnant, and her husband standing there saying, "What are we doing, Lisa? What are we doing?" But anyways. premature atrial contractions, you guys can see these. The way to pick these up is this rate. It kind of depends on what the underlying rhythm is, but a PAC is going to make the rate irregular. The P wave, generally, for the most part, it's going to follow whatever the underlying rhythm is. So let's say in this one, the underlying rhythm is a normal sinus. So all those P waves, except for the two, actually look good. They're upright. They're rounded. They're within the normal time. But a PAC is just right here. Okay. Sorry, it looked like my dog was having a seizure. Anyways, it's right here where that P wave is early. See, this T wave hasn't even had time to completely repolarize. This PAC here is the atria contracting early. So everything's not quite repolarized, and the atria are like, "Ooh, I wanna contract again." So that's how you tell what a PAC is. Alright, so a PVC looks like that. This is the ventricles contracting early. Generally, the rate's going to be normal, except for it's going to be irregular during the PVCs, depending on how many there is. When there's a PVC, we're not going to have a P wave. We're not going to be able to measure that PR interval during a PVC. In a rhythm like this one that we're showing, most of the QRSs do look okay, except for the ST segment looks elevated to me on that one as well. But during a PVC, those QRS complexes are going to be extremely wide and bizarre looking. Kind of looks like to me like a kindergartner was coloring. And it happens before it's expected to, so it's an early beat that is wide and bizarre. So bigeminy is when this PVC occurs every other beat. Trigeminy is when this PVC occurs every third beat. So that would make quadrigeminy every fourth beat. Also, when you have two of these together, it's called the couplet. And then when you have 3 or more PVCs in a row, it's considered a run of ventricular tachycardia. So know all those terms. They'll be important, I promise. Causes for these may be stress, caffeine, heart attack, dig toxicity throws PVCs, and sometimes people just throw PVCs as a chronic thing. The worrisome thing about this is that it can actually convert to VTAC or VFib, so it does need to be watched close. Alright, idioventricular rhythm. That's what it looks like. It's ST depression on that one. So the biggest thing here is the SA node has failed, the AV node has failed, so those impulses are coming from way down in either the bundle branches or the Purkinje fibers, so it's going to be slow. This is when the heart, it's one of their last steps before the heart just completely quits. So the rates, you're going to see ventricle rates because the atrias aren't contracting anymore. So the ventricular rate is going to be 20 to 40. So all you see is the QRS. The rhythm usually is pretty regular. Since the atria aren't contracting anymore, there's no P waves, there's no PR interval. There's wide and bizarre QRSs, and either, I think the T wave is, like I said, in this case it's called deflection, it's upside down. And these people are very close to dying. This is where we're going to give atropine, PASM, dopamine, CPR, because generally this is when they pass, right before they pass away. Agonal rhythm. This is after an idioventricular rhythm. It's basically an idioventricular rhythm, but it's less than 20. So it ain't much. There's no pulse, there's no blood pressure. Alright. Moving on. VTAC. This is kind of like a run of PVCs, if that helps you remember it. Rate greater than 100, like 100 to 250. The rhythm, you can see the ventricular rhythm is regular, but there is no atrial rhythm in there. There's no P waves, there's no PR interval to measure. QRSs look alike, but they're wide and they're bizarre. They're greater than that 0.12. We're going to be doing CPR, we're going to be doing ACLS protocol. Ventricular fibrillation. This is kind of where the ventricles are fibrillating. It's not coordinated. There's no way to tell what rate it is. The rhythm is rapid, unorganized. No P waves, no PR intervals. There's really no QRSs. And the only way to pull them out of EFib is CPR. This is seen in people with drug overdoses, trauma, and very acute MIs. Torsades. As you can kind of see on torsades, torsades actually means twisting about the points. So you can kind of see, I think I have another little picture down here. Maybe? Yeah, well, I kind of see it. It looks like one of the birthday ribbons. When you twist the crepe paper and hang it up, that's what it looks like to me. There is no atria. It's the ventricles. Rhythm can be regular or irregular. There is no P wave, there's no PR interval to measure. The QRSs are going to be wide and bizarre. Some are downward, and then they're going to do upward for a while, and then they're going to do downward. This happens when you see tricyclic antidepressant overdoses, and then low potassium and low magnesium can actually cause this. For somebody in torsades, we're going to be giving them mag sulfate and cardioverting them, CPR. Sometimes it will terminate on its own, but it'll reoccur. So. Asystole. That's straight line. There's nothing there. Signs and symptoms of asystole, they're dead. And then our last one, PEA. The strip looks wonderful. The strip looks like this person is doing great. Normal sinus rhythm. So the electricity is working in the house, but the plumbing is not. So it looks like they're doing great, but the patient is dead. There's no pulse, there's no heartbeat, nothing except for electrical activity. Alright. So then I am going to pull up the heart blocks real quick. I got just a couple pages of these, then I'll post this, and then I'll post the other review. Alright. To help remember heart blocks, remember it progressively gets worse. So in the first one, there's longer PR interval, and by the third one, the atria and the ventricles are not talking at all. So, the first one, that PR interval, right here, is a lot longer than we want it to. Greater than 0.2 seconds. So when the SA node fires, and it goes to the AV node, and then it goes down to the ventricles, it's blocked somewhere between the SA node, the AV node, and by the time it gets down to the ventricles. So that's why it takes longer for the ventricles to contract as compared to the atria. So the rate kind of varies. It depends on what the underlying rhythm is. Generally, the rhythm with the heart blocks, if it's just a heart block, is regular. There's a P wave before every QRS. It's upright and uniform. But the difference is where that interval is prolonged. And all QRS looks good. Because the block is happening by the atria. Or between the atria and the ventricles. Sorry. So then we go down to Winky-Bach. Second degree type 1. As you can see on this one, PR interval here. This one gets a little bit longer to the QRS. This one is even longer yet. And then here's the P wave and no QRS. So that PR interval slowly gets longer until there's a dropped beat, a dropped contraction of the ventricles. So, first degree, there's always a longer PR interval. Second degree, that PR interval slowly gets longer until the ventricles don't beat. Alright. Second degree heart block type 2, the Mobitz. We're going to see a slow heart rate. The atria, the P waves are going to be regular, but the ventricle rate is going to be irregular. The P waves, they all look good, they're upright and uniform. The PR interval, when there is a QRS, the PR interval is going to be within the normal limits, but generally it's just going to be dropped beats, dropped QRSs. Let me note up here, if the PR interval is normal and the QRS is prolonged, like these wide QRSs, most likely second degree type 2. If the PR is prolonged and progressively prolonging, and the QRS is narrow, then it's most likely type 1. We move on to third degree. Third degree, the atria are beating, and the ventricles are beating, not breathing. SA's node's firing, the AV node's firing, but they're not talking. So the atria are doing their own thing, and the ventricles are doing their own thing. Usually those atrias are going to be at their normal rate, but the ventricles are going to be slower. P waves are normal. QRS complexes are normal, but they're not linked. There's not a P for every QRS. So I hope that helps with learning the blocks. Know your blocks, review your blocks, know what's going on. And then I'm going to post this, and then I'm going to, once that loads, I'm going to post the other review sheet.